So the indication was GI bleed.
Ooh, ooh.
I'll show you the coronal. Yeah, what do you see?
There's a annular mass in the right colon,
Uh-huh.
and then there's is it a necrotic node adjacent to it?
Yep.
And then
Another big node.
there it is. Ooh.
So thoughts about this?
Um, well, I think about for sure adenocarcinoma. Um, with lymph node metastasis, but we've been surprised before. Uh, or
And it's kind of
like
aneurysmal.
like lymphoma stuff, but I mean it needs to get colonoscopy and tissue diagnosis.
Yep. So this is just kind of almost a companion to one that we saw a few weeks ago. This patient had a somewhat remote history of melanoma, and this was actually another melanoma metastasis to the bowel.
Mm,
So I think
wow.
just always think about it. Even if the patient has a remote history, bring it up,
Yeah.
don't be surprised. And it can definitely cause this aneurysmal dilation. I think Yashant showed us that when I was showing the prior case.
Mm,
These necrotic nodes are also a little weird for lymphoma. They usually have, even if they're very large, they're usually like kind of bland and not necrotic. So
mm.
those are just some of the, ancillary features. But I think lymphoma is a good look here, aneurysmal dilation, and then melanoma can do this exact same thing. So this was melanoma met. And then I actually have another one. Hold on, I'm just gonna pause for a sec.
It's the last.
You did what?
Oh no, I looked up open evidence metastasis melanoma mets to the colon.
Yes, tell us more.
So usually small bowel metastases are way more common in the colon. So up to 90% are small bowel usually, and
Mhm.
20 to 25% are colon metastasis, and it only represents 15% of GI melanoma metastasis. And it can happen anywhere from 1 month to 24 years.
Yeah. Yeah, mine I think was like 10 years out.
Wow.
Hi Yashant, hi Jordan. I just showed a case. I can,
Hi,
oops.
Hey
do you
everyone,
guys hear me?
Oh,
Yes.
hi, Shot.
and I'm with
Hi, Jordan.
Ruben, Kadar.
Hi.
Oh,
Sorry, I
hey.
don't have cases. I'm at the airport.
Oh, that's okay. Hold on. Let me stop sharing for a sec. Do you want me to show you the case that I just showed?
That's crazy commitment, Yashan.
Yeah, if you can quickly.
Yeah.
Thank you. Hi, everybody.
Where are you going?
I'm going to Philadelphia.
Oh, nice.
I have a grandparents there.
Oh,
Nice.
congrats.
Thank you.
I'll just quickly show this. This was the case I just showed where we saw this thickened aneurysmal dilation of the colon.
Mm-hmm.
And there was also these large necrotic lymph nodes.
Mm-hmm.
So we were thinking about lymphoma, but this patient had a remote history, like 10 years ago, of melanoma, and this was actually melanoma metastases. So
Wow.
I remember you showed one also like
Yeah.
that had like, you showed the patterns of melanoma mets to the bowel, and it can do this aneurysmal stuff.
Mm.
And I was saying like these necrotic nodes are kind of a little unusual for lymphoma.
Mm-hmm.
So yeah, this was just a melanoma met to the bowel.
Yeah.
And then I have a companion case that I was going to show. So this one, patient had a bowel obstruction
Mm-hmm.
due to this mass. This involved the small bowel going into here, and then there was this sort of like necrotic exophytic mass. I'll show you the coronals. And I actually showed a case very similar to this a few weeks ago that was a melanoma met, but
Yes.
this one turned out to be diffuse B-cell lymphoma.
Okay.
So I don't have a good take-home point except that they can look very similar to each other.
Yeah. Yeah.
And even lymphoma can be necrotic and kind of exophytic and infiltrative and maybe just differential.
Yeah. I mean, if I can add two things here, like
Uh-huh.
One is, yes, classically we have been taught that lymphoma is going to cause aneurysmal dilation, which is true. And of the 4 or 5 patterns that lymphoma bowel appears, lymphoma small bowel, the commonest is actually just a nodule. The commonest is not the aneurysmal pattern. It's one of the patterns, pretty characteristic of lymphoma, but that's not the commonest. Second thing is, um, more anecdotally, with your cases and with my cases that we have seen, um, one of the cases that I showed 1.5 years back was colon, which was aneurysmally dilated. We thought of lymphoma, but then it turned out to be adenocarcinoma. And statistically speaking, 95% of large bowel cancers are adenocarcinoma, and lymphoma is a very in minority. Similarly, we saw melanoma mets. We also saw GIST case of small bowel. So aneurysmal dilation is also a pattern with GIST. So yes, when we see aneurysmal dilation of bowel, we'll always think of lymphoma, but then that will not be the only differential. Can be one of the take-home points here. And with lymphoma, lymphoma can be necrotic if the patient is immunocompromised, treated, or the lymphoma is of like worse grade. And DLBCL is anyways a worse grade. So if we see heterogeneity like this, don't get surprised, is the second take-home point.
Awesome. I like the point that you just said that like colon is going to be more common to be adenocarcinoma regardless of how it looks, and can even kind of be look in many different ways, including aneurysmal dilation. So, okay.
I think I'm good. So we were doing this MRI for a patient with adrenal nodules, and they wanted to characterize this. So this is what the adrenal nodules look like here. Coronal. Let me give you the axials. Prior bypass.
They're super low density.
Mm-hmm.
They don't have any infectious symptoms, right? Like not like
No.
TB. Hmm. And then adenomas will be low density, but not usually this kind of maintaining the adreniform shape.
Mm-hmm.
Like
Yeah.
a bit more like lymphoma.
Just hyperplasia.
Yeah. And that's what I think it is. Um, so and this was a really great learning case for me because I learned that there's different types of hyperplasia. So like Aarti said, it's not a discrete nodule, which is what we want to see with adenomas. And this is more diffuse. And then within the hyperplasia, there's different types. There's diffuse hyperplasia, micronodular hyperplasia, and macronodular hyperplasia. And the I think this one's more kind of diffuse because I mean, even though it does look a little bit lobulated, maybe, but I think it still has more of a diffuse look. And this is more of an ACTH dependent pathway. And what I learned about is this condition called macronodular hyperplasia. And I'm going to share with you a paper. I hope I can find it. Um, can you? Okay, so this is macronodular hyperplasia, and they call this like clusters of great appearance. I can see kind of the clusters with multiple bilateral macronodules, and they get enlarged bilateral adrenal glands, like we see here. And the important thing to know is that it's like a unique entity, and it's associated with a specific mutation. And they can also get meningiomas and stuff. So, and that's different from diffuse hyperplasia, which is different from micronodular hyperplasia. So even though they um, are all hyperplasia variants, they have different causes, etiology, and pathways.
Nelly, do you know how much of these hyperplasias are hormonally active?
So it says from open evidence, ACTH, you get elevated ACTH either from pituitary or ectopic source. So that is hormonally active. For micronodular and macronodular, I don't know what percentage, but I can look it up and give you more information.
So, is it sort of like we would call it adenomatous hyperplasia, or is there other types of hyperplasia, or it's all in a spectrum of like related to adenomas?
Uh, I don't know that it's part of a spectrum, in the way that we think about it being going from one thing to another as part of a spectrum. I think they're like different entities. So
But they're all related to like underlying adenomas, or
so
no?
so like macronodular hyperplasia is due to a very specific gene mutation. Um, which is and they're treated so like and if you have macronodular hyperplasia, they do unilateral adrenalectomy of the larger gland. And they get like and actually they have response in 95% of the case um, to uh, because of the adrenal activity. A micronodular hyperplasia, they get bilateral adrenalectomy to to it's treated for overt Cushing's. And then diffuse hyperplasia, they're treated with um, depending on what the cause is. If it's like a pituitary source, and they do like a transsphenoidal surgery or whatever. So that I think they're different rather than part of a spectrum. Like dysplasia that becomes an
Got
adenocarcinoma, for
it. Got it.
example.
Yeah. Okay. I want you to ignore the uterus and just tell me what you think is going on here.
There's like a ugly
Is there some mesh or
mass,
something?
or yeah.
Great thought. Like, why are you saying mesh?
It looks very wavy and very dark.
Yeah, it's pretty dark. So here's our bladder, urethra, and where the normal vagina should be, there is a rectum. You can see that it's prolapsing here. But where the vagina should be, it looked like this. And then I'll just show you on like there's it looked like this. And then there's a lot of susceptibility, foci of susceptibility in this area. So anyway, this is what is called a colpoclesis, which is basically they sutured up the vagina so that it is now closed. And it's just looking up about it. Oops. Basically, they say it's a very like like a fast and effective way of treating prolapse if you are no longer going to be having vaginal intercourse. So they basically just sewed up this entire vagina, and that prevents the uterus from prolapsing down. We still have this rectal prolapse, but it was helping with the uterine part. So just something to be aware of if you see this kind of, post-surgical appearance, the vagina has lost its normal anatomy, there's a lot of susceptibility. There is this procedure called a colpoclesis. This patient was in her like late 90s, so I think she was more concerned about her prolapse issues than maintaining vaginal integrity.
What's going on with the endometrium?
Yeah, I told you to ignore the uterus. Yes, so we thought that there's a malignancy up here. Basically,
Yeah.
you know, because of her age, she's choosing like they're not really going to do anything about it. So
All right, so this person had a history of RCC with a left-sided nephrectomy. And so the findings here within the gallbladder, so we see this like heterogeneous thickening, like projecting within the lumen, T2, isointensity, restricted diffusion, and then our post-contrast enhancement there. And so this was taken out and we have the pathology, but it's curious differentials that you all are thinking.
It's
RCC
the one that
Mets.
RD says, ICPN.
yeah, that's what I'm thinking because it looks like multifocal papillary frondy. It doesn't seem to definitely be invading beyond the wall, whereas a huge gallbladder cancer of this size would, like if it was all just invasive adenocarcinoma, might be more invasive. So thinking
It could be even
ICPN.
RCC Mets.
Yeah, yeah. That's what this
Very
ended up being was
hypervascular.
RCC Mets. in the
Oh, wow.
history of RCC. Yeah, but yeah, we initially said that this could be like, primary gallbladder, but they took it out, and that's what the pathology showed. There was no other lesions, I believe, on this one. It was all confined in the gallbladder.
Wait, has it been, I mean, it's just so diffuse. Is it like, was there some evidence of it prior, or just all of a sudden, like diffuse bladder
Let
metastasis?
me see. It's been
Too much imaging, Nelly. We have an old CT from a few years back.
I don't.
Few months back.
Oh yeah. Oh yeah.
Was there on that, and looks like it's recruiting some vascularity to it or some. Are those calcifications? Calcification.
Mm, that's cool. You always think about melanoma mets to the gallbladder. I
Yeah.
have not seen RCC to the gallbladder.
And so multifocal, like studying the entire wall.
Very cool.
This would be a good case report.
You think,
Yep.
Yashan?
Yes.
We'll put somebody to it then.
Jordan.
Yeah. Yeah, who could we have do that? Only had a fellow or something.
So I looked up on open evidence about melanoma metastasis to the gallbladder, and it says it's rare, but it's the most common metastatic tumor to the gallbladder, accounting for 60% of gallbladder metastasis. And it's found in 20% of melanoma patients at autopsy, but rarely symptomatic in life.
Wait. Which is most common, RCC or melanoma to the gallbladder?
Um, Melanoma metastasis to the gallbladder.
Uh,
Oh, no. I'm sorry, it wasn't melanoma, right? It was RCC.
yes, this patient was RCC.
Yeah.
I'm sorry, you said melanoma earlier, and that is the most common metastasis of the gallbladder. Sorry about that. So for RCC, it's extremely rare and it occurs in 1% of metastatic RCC. It could be synchronous or metachronous, which is metachronous is seen in most of the cases, 70%, and 70% are asymptomatic and discovered incidentally, and more common in men, twice as more common in men, and older men, like average age of 62.
Okay, so case reportable.
Yes.
With
Got
patient consent. This is a patient with um, alcoholic diffuse liver disease.
Bleeding because of ruptured HCC or whatever that lesion is.
Yeah, right here. Right. And then I have an arterial phase right there. There's a little active bleed. So yes, it's bleeding HCC, and it doesn't happen often, but can happen up to 15% of patients with HCC. And for some reason, a higher incidence in Asia.
Just a few reminders.
Uh,
Remember, the carry-on will be tagged with a valid tag if you don't already.
Thank you. And then, so there's certain risk factors for bleeding HCC. So male, gender, cirrhosis, hypertension, and big tumors, and subcapsular location. And the tumors that are in segment 2, 3, and 6 are at the highest risk of rupture. So the patient underwent, and then you can get active extravasation, like in this case, and that portends a worse prognosis. But there's this sign called enucleation sign, and it's the most specific sign for bleeding HCC. And I'm going to share my screen with you really quick to show you what that enucleation sign looks like. Can you pause for a sec? Okay, so this is a screenshot that I took from a paper about that enucleation sign. And so it looks like the lesion's like coming out, basically, of the liver, kind of crazy looking. But that is apparently pathognomonic for bleeding HCC. It's a super old paper, so 2001. But anyways, interesting.
I'm not sure this sign helps me. Like you see it's a lesion that's bleeding, right? Is the enucleation the like little disrupted part?
Yeah, it looks like an eyeball, like an eyeball that's coming, like it's getting enucleated, kind of removed.
Got it. As opposed to just saying that the lesion is exophytic.
I think it's actually coming out, like it's
Like
like
moving.
it's moving and it's coming out of the liver.
Got it, got it, got it. Because the capsule is ruptured and then it's able to like move.
Yeah, like just it's yeah, crazy, right? It's just like imagine a ball of HCC coming out of the liver, getting
Mhm.
enucleated.
The cases I've seen of that at our institution, they always treat them with TACE if they're like unstable and bleeding. And it seems like those follow-ups, they always have some like local residual tumor compared to like, Y90 or something that they seem to do a lot better that are, scheduled outpatients, obviously. But I don't know if that's uniform across the board, but that's more on the treatment side.
Yeah,
Mhm.
yeah, we this patient underwent TACE as well and did very, very well.
So,
Oh my gosh,
yeah, what do you guys think?
It's like an infected,
prosthesis. Yeah.
yeah,
Yeah.
prosthesis.
Yes, so there was no
Mm.
prosthesis actually. You can see
Oh,
this patient has like a lot of calcification. So they actually have
Oh, is this
like
the
a lot of
same
cal
case?
yes, 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 yes. This is the case
Okay.
I showed you, Shant. So this patient has a history of like ANCA vasculitis and actually ended up with penile necrosis
oh,
and yeah, and like gangrene of the penile shaft. This is all just calcification. This is not a prosthesis.
wow. So it's calcifying the tunica? Is that what, or
Or the dead tissue calcium.
Yeah, I think it's like they have a like they have some calciphylaxis and then they also had ANCA vasculitis. And then Yashant sent me this article that I'm going to show you. So there are different types of vasculitides that can lead to penile necrosis. And oops. Um, this was the case in this case report. And actually, this penis, because of the vasculitis, led to necrosis and then it auto amputated. So it actually sloughed off.
wow.
Of this being the end organ recipient and vascular.
Yep. Hmm.
It's wow.
So just a companion case to what Jordan showed. So this patient also has a nephrectomy, and at this time, this was thought of as a gallstone, and we didn't say much about it. But a couple of months later, this actually became big, and this was taken out, and this was RCC Mets.
This is scary because it's dependent also, Yashant, on the first one, right?
Say it again.
Like it's in the dependent portion on that
Yeah,
old scan, and it almost looks like it has a central lucency with two stones next to each other.
yeah. So that's what it was called as stone, and obviously it looks like one, and then um, eventually it grew up. So
Nice.
Yeah.
Now you're going to make me question every gallstone in an RCC patient.
not really. I mean, that looked like one, and gallstones can have variable attenuation, so it's very difficult to say.
Heh.
Okay, go.
This is a patient with migratory abdominal pain, predominantly right-sided. Ah, yeah, I don't know why it's not going down into the pelvis. So let me just pull up the coronal.
What is all that in the right lower quadrant? Is it like mucinous appendiceal thing or?
Yeah, good.
Yeah,
Um,
inflamed mucosa.
Yeah.
so this is it was resected and came back as appendiceal signet ring cell adenocarcinoma. It's an exceptionally rare and aggressive cancer, and it can mimic appendicitis. I think this was initially read as appendicitis. It was managed many, many years ago somewhere else. And then it has a high metastatic potential and worse prognosis. So you get really significant thickening, nodular enhancement, cystic dilatation of the appendix, and the diameter can exceed like 1.5 centimeters. Um, and how do you distinguish that from appendicitis? So appendicitis, so the features that favor more cancer is like really severe thickenings. I mean, a tumor, like appendiceal diameter greater than 1.5. If you have mural calcifications or appendiceal mass, um, features that favor appendicitis, you can sometimes you can see appendiculith, uniform wall thickening, and a preserved target sign on ultrasound. And the diameter is usually less than 1.5 centimeters. But most appendiceal neoplasm present as acute appendicitis, so they can co coexist.
Can you scroll down through this? Hmm. I think, yeah, like that base of it looks really soft tissue thickening, right? Right there. Yeah, that looks really sketchy. I feel like this one doesn't look that much like appendicitis, but I would have maybe thought like lamin, but then that soft tissue stuff, I might have even thought like, hey, maybe it's just like a colon cancer that is causing, I don't know, mucinous dilation or appendicitis, I guess. But I think I would have focused more on that area, like the cecal base, and said like, I'm concerned about a colon cancer. But either way, yeah. So like when we talk about mucinous neoplasms of the appendix, there's the low-grade lamin, then high-grade Hammond, and then there's like actual mucinous adenocarcinoma, which it sounds like this one was. And
Mhm.
signet ring cell is a like a more aggressive subtype. I think occasionally they'll still do hypex for these patients, but it's much more common for patients with like ruptured low-grade appendiceal mucinous neoplasm or lamin.
And Hammond, which is what Aarti said, is high grade appendiceal mucinous neoplasm.
Hmm. Okay, this is a thyroid. So you can see that, like, can you guys see this?
Yes.
Okay. What do you think? They look suspicious, right? They're very hypoechoic, kind of irregular borders, very vascular, although that's not really helpful. Large hypoechoic multiple masses.
Mhm.
Um, and I kind of withheld some history, but basically the patient also had a history of RCC, and these were biopsied, and they were RCC mets to the thyroid.
Nice.
So just on the RCC theme, RCC can go anywhere. It's rare for RCC to met to the thyroid. It's only like 1.1% of thyroid malignancies will be mets, but it does happen. And of the malignancies that met to the thyroid, the most common are RCC, colorectal, lung, and breast. So yeah, it's possible. And yeah, they just have that really kind of like irregular border, hypoechoic. So those are the concerning features.
Yeah, easily it was Tyrex 4 plus lesion.
Hmm. I mean, this is probably Tyred's 5, right?
I think so, yeah.
Oh, sorry, the biggest one, yeah.
Yeah. So this is an RSNA 2025 exhibit on Thai. Oops, sorry. RSN 2025 exhibit on thyroid, and this just shows, as Aarti said, like most common malignancy to metastasize to thyroid is RCC, followed by these couple other. And we have examples here as well from small cell lung cancer.
Looks
Yeah,
very
that,
similar to my case
yeah.
and pretty different than like typical, papillaries that'll have like the microcalcification
Mhm.
or follicular. Yeah.
There are two other things, if we have time, I would want to show. Again, this is just thyroid specific. So
Yeah, sure.
I like this case of LCH in thyroid as well as parotid.
Is there anything specific about the imaging here? Non-specific.
Not really, but just it was cool that, histiocytosis, which now are like histiocytic tumors, they can go to thyroid as well, other than pituitary. So LCH also goes, Ardem-Chester goes, Rosai-Dorfman also goes to thyroid. That, and the other thing is, if you see fatty density in thyroid, one differential is going to be adenolipoma, the other differential would be amyloid deposits. Like if you see fatty density or infiltration or fatty intensity or echogenicity, so there will be at least two differentials, not just lipoma, but even amyloid.
Wow, that's a really dramatic CT example of like with the fat.
Yeah.
Wow, really interesting. Okay, learned something new.